In fact, it's a very short case and mostly a presentation on the topic because there is no so much discussion about that. I would like to start by congratulating Lucia and Victor and all the group for this meeting. It's a very nice meeting. I'm sure that our young colleagues are happy to be here, to meet, to learn, and we are happy to learn with them. And once again, Lucia, congratulations for that. Congrats. So, heart failure, it's a very common problem for us in cardiology, of course. I'm not sure that for angiologists, it's the heart of them problems. I will try to convince you that there is a real problem. These are my disclosure. And I will start by the case, which is, we'll say, very, very simple. It's in fact, I started from the case published close to the guidelines. It's a 75-year-old diabetic woman which has a cardiomyopathy with an ejection fraction of 40%. New York Heart Association II, and which has absolutely no complaint about her leg. Thus, for you, the clinical presentation eliminate PAD. Yes or no? What was the harm? Which yes or no? Yes, no? No. You're right. Are you going for further evaluation in these patients? Yes. Yes, most of you are going for further. In fact, I'm not sure about that in the real life. You are going for further examination here in this room, and I hope that after that you will go in the real life. But when we make surveys about that, we can see that most of people are not going further to detect a PAD in this kind of patients. Perhaps you have other experience about that. Yes, which one? You have several choices possible. 1, 2, 3. 1. 1. 1 and 1? 1 and 2. Yeah, 1 and 2. You're right. And in this case, the lady has distal pulse abolished on the right side, reduced on the left side with an IBA of 0.7. On the right side, 0.8 on the left side. And there is no reason to go for imaging in this case. And what is for you the explanation in the fact that this lady doesn't complain despite a quite severe arteriopathy? Neuropathy? There is another reason. She is limited by her heart. She is 40% ejection fraction, and when she is walking, she is walking very slowly. And she is limited by short bracing, but dyspnea. And we have, I think, to be always careful in this kind of patient. They will not express any symptomatology, particularly in lower limb. And sometimes, that's out of the subject, they are not expressing very important dyspnea. They are limited, they are adapting their activity. And the recommendation here, I will see that further, it's for screening for lead in patients with heart failure. And once again, we've performed some surveys among cardiologists, and 2% of cardiologists were using ABI in this kind of patients. That was perhaps 10 or 15 years ago, but I think it's always the same thing. And sometimes it's difficult as far as these patients are also, it was not the case here, in atrial fibrillation, and then ABI is much more difficult. So, his treatment, when we see her, was aspirin, ramipril, and bisoprolol. Are you keeping this treatment? Are you changing? 2 questions.
Can I have a question?
Yeah.
Why did you exclude coronary artery disease in this patient?
We didn't exclude for the moment, but at the end, we have proposed an angiography, coronarography. As far as stress test, not possible. As far as it was a woman with diabetes, and scintigraphy is not so accurate. In fact, she is diabetic. And the renal function, I don't precise. The renal function was a little limit, so we were going for.
The reason I ask, because this will define treatment according to presence or absence.
I not fully agree with you on this question. We'll see then later regarding the treatment. So, what do you think about the treatment? Aspirin. Are you keeping aspirin? Yes or no? Yes. Why? On which data are you relying to keep aspirin at this point?
There must be a reason for that.
Sorry?
There must be another reason for the aspirin.
She came like that. Because most of the people with cardiomyopathy are treated with aspirin. Why? Don't know. I will not start again the discussion which occurred yesterday. I was not there, in fact. I heard about that. So, aspirin. Ramipril. Are you keeping ramipril? Yes. Bisoprolol? Yes. Despite you find an low IBI? Yes. Doesn't matter. We agree. Where we disagree, not really disagree, but what we have changed is aspirin. And we change aspirin to clopidogrel. Why? PAD.
And no need to add anything else?
Nothing else at this point. Statin. Yeah. Okay. No, statin. Statin is, in fact, I am genetically addicted to statin. So it's so natural that, and working a lot on statin. Of course, statin. She had statin. I was just focusing on the treatment of heart failure. Statin, of course. But we change for clopidogrel. As far as there's no real reason at this stage to keep on aspirin. And I don't believe that aspirin is the best treatment, but it's another question. And so this was the case. And in fact, heart failure is something very frequent in patients, and mostly in patients over 70 years. And most of patients with heart failure are coronary patients, and this represents around 70% of our patients. And you then imagine the relationship between PAD and the coronary and heart failure, as far as once again, coronary disease is the most important etiology. So what are the markers of worse prognosis in patients with heart failure? Demographic data, and you looked at older age, male sex, low socioeconomic status, and I will insist on this point. And these are points where heart failure and PAD are meeting. These patients are sharing the same risk factors. And the other marker of worse prognostic for patients with heart failure is, of course, PAD, lead, and carotid disease. And here we are meeting the two conditions. And if we look at this slide, we can see that atherosclerosis is the common point between the two conditions. And of course, diabetic, of course, inflammation, of course, hypertension are markers of PAD and are markers of heart failure. So we can't separate the two conditions in those patients. There are some studies about that. Here, a Swedish study, not a lot of patients, 400 in each arm. And we can see that in patients with PAD, the prevalence of a low ejection fraction is pretty high. Pretty high mostly when there is an association between lead and carotid disease, which is the most important condition. And here we are again seeing the potential relationship between CAD and heart failure and PAD because of the role of CAD on coronary disease. Here, which is interesting too, it's a paper, it's a pretty old paper, where 200 patients were screened for heart failure with transthoracic echocardiography. And they see that in symptomatic patients, the rate of, in a symptomatic patient, the rate of patients with low ejection fraction was twice higher than in the general population, which is pretty important. I don't know if you have this experience in your patients with PAD. Are you finding a lot of patients with low ejection fraction or not?
If you are searching for it.
Sorry?
If you are searching for it.
Yeah. And the not is mostly to express the lack of diagnostic. And I think that perhaps the most important thing is to think to go and look for that. Of course, we'll see later. Of course, ejection fraction is not the single point. And most of these patients has heart failure with preserved ejection fraction as far as they are old patients with arterial disease. And this is the most important mode of expression. In the IREX study, you know, IREX study is a huge study, huge cohort of 14,000 patients. And they found that not only there was a high rate of patients with low ABI, but the lower the ABI was, and the worse the prognostic was in these patients, and the higher the rate of heart failure was important. So not only an AB and low ABI is predicting heart failure, but the lower you will find the ABI, the more chance, if we can talk about chance, the more risk of heart failure we will find. And when we are looking now, the prognostic after intervention for PAD, this prognostic is, of course, worse in patients with heart failure. Why? General condition, lower output, and those are things we have to keep in mind when defining a strategy for treatment of these patients. We have data from the TopCat study. I think you are aware of this study. If not, it was a study looking at the benefit of anti-aldosterone in patients with preserved ejection fraction heart failure. The study was negative. But we have seen in this study, in this paper, that in fact PAD relates to a lower benefit and a high rate of risk of hospitalization for heart failure, a risk of MI, not for risk of stroke, but risk of mortality, total and cardiovascular. In fact, in these patients with preserved ejection fraction, a low IBI is also predicting a worse prognostic. It was not surprising at the end. That means that when looking for heart failure in those patients, we don't probably need only to look to ejection fraction, but to look to the other parameters when performing the echocardiography. And I will not go for the diagnostic of preserved ejection fraction heart failure. What about prognosis? And here we have a meta-analysis which tell us that a lead in patient with heart failure is also of worse prognostic. And there is a 1.4 risk of mortality in this kind of patient, comparing a patient without heart failure, without lead. And that's right for mortality, cardiovascular mortality, and also for hospitalization. As far as you know that in patients with heart failure, hospitalization is one of the major point and major outcome we are looking for. Why? Because after hospitalizations, the rate of death is very important. And why? Because from an economic point of view, heart failure costs a lot of money when you are going to hospitalization. That's why in several countries we are going for different strategy than hospitalization, another subject. What about treatment? You are all expert. There is no limitation of beta blockers in patients with PAD, except to be very cautious in patients with critical limb ischemia. And I think you all agree with that. Should there be a choice between beta blockers? I'm not sure it's really important, but we shall keep in mind that beta blockers are of really important in this patient regarding heart failure and not regarding coronary artery disease, because today we are much more discussing the indication of beta blocker in stable coronary artery disease. And in the end, the importance of lead must be discussed, and perhaps here imaging could be important. It's when you are looking for vascular access for cardiac intervention, and that's all, of course, something which is important, but I think here there is no doubt that's much more performed. So I will conclude here that evaluation of the cardiac function is really of importance in patients with PAD. That also in patients with heart failure, measuring ABI is of major importance. And we have to keep in mind that patients are limited for walking, and so the clinical expression of the disease is very limited. And here are the guidelines. And these guidelines are resuming what I have said, that in patients with symptomatic PAD, screening for heart failure by echocardiography or by peptides is important to A, and screening for lead may be considered in patients 2B, 2AB, let's say. Thank you.